We're going to talk now about the mechanism, the diagnosis, and the clinical findings of the supraventricular tachycardias. There are four main mechanisms of supraventricular tachycardia, and that includes the AV nodal reentrant tachycardia, most frequently, as we discussed, the AV or atrioventricular reciprocating tachycardia, 30 to 40% of the patients, atrial tachycardias, and atrial flutter. We will start with AV nodal reentrant tachycardia, which, as we said, is the most frequent. We still find it even in pediatric cases in about 10% of the children that are referred to us for SVT. They're more frequent in women, double the number of male patients. And one really pathognomonic symptom that the patients report is the neck pounding, or the neck throbbing sensation as they have their palpitations. In up to 90% of the cases, the tachycardia is what we call typical AV nodal reentrant tachycardia, and I will explain with the next slide. And in that typical tachycardia, P waves may not be visible on the surface EKG, or they may appear in the terminal portion of the QRS complex, and that's why we characterize this tachycardia short RP tachycardia. So concentrating on this first part of this graph here, the schematic of the conduction system in the heart with the sinus node, the atrioventricular node with the slow and the fast pathway. Almost everybody is born with a dual AV nodal physiology, but it's only a few of us that will further develop atrioventricular Avnrt, and others we don't. The mechanism for the Avnrt, the typical Avnrt, is when the conduction, the impulse, will travel down the slow pathway and quickly find its way up the fast pathway, initiating this reentry around the AV node that can very fast and sometimes simultaneously activate the ventricles and the atria. So in this example, because the atria and the ventricles are activated at the same time, the P wave actually is hiding inside the QRS or just after the QRS, and this is what we call short RP tachycardia. So this is the example in another schematic that you can see the reentry happening around the AV node. This is a cross-section of the heart with the atria and the ventricles. In yellow is the conduction system, sinus node, AV node, his bundle, and left and right fascicles. And as you can see on the EKG here, as the atria and the ventricles get activated at the same time, you can hardly see the P wave right after the QRS, making it a short RP tachycardia. This is a characteristic EKG, although sometimes it can be confusing just because the rate is relatively slow, about 115, 120 beats per minute. But this was an older patient of ours, 85-year-old gentleman, who had actually been up on the floor for a few days being treated for sinus tachycardia because he had come in congestive heart failure. And so one evening after his heart failure had improved after a lot of diuresis, he spontaneously converted to his sinus node, which was going at 50 beats per minute. And we were able, or the team was able, to tell the difference between this tachycardia and the sinus node, and they referred him to their EP colleagues who took him to the lab, and we did an EP study and ablation of this mechanism. But what do we see here? We see a narrow complex tachycardia, regular, at a rate, as we discussed, of about 120 beats per minute. And the next thing that I look for is to try to see a P wave in any of the leads. And really here, it's very hard to discern any P wave, but maybe a little R prime at the end of the QRS in this lead, which makes it really a typical EKG for Avnrt. In a little more characteristic way, a younger patient with Avnrt, and this is the EKG. Again, narrow complex tachycardia at about 150, 160 beats per minute, regular, and looking for a P wave. Someone gets the sense that maybe a P wave is there right after the QRS, a P wave may be there right after the QRS, again making it a narrow complex tachycardia, short Rp tachycardia. And this was confirmed later during her EP study that was Avnrt. The next mechanism we're going to talk about is the atrial ventricular reciprocating tachycardia. It has to do with an extranodal accessory pathway, which connects the atria and the ventricles in addition to the normal conduction system of the heart, the atrioventricular node. This pathway may exhibit antegrade, retrograde conduction, or both. And in the cases that not only conducts retrogradely from the ventricles to the atria, we call it a concealed pathway. This is an example of a Holter monitor that I was reading one day, and we were fortunate for this patient who was getting a Holter monitor for palpitations to capture the onset of the tachycardia. And we can see how we went from this wide, complex, slow rate rhythm to the fast, regular rhythm that we call supraventricular tachycardia. Looking more carefully, there was a short Rp interval. Here is a P wave, here is a P wave, a short Rp interval, a delta wave, and we're going to talk about that, but this is what we call pre-excitation. Delta wave mainly positive here and negative here, and then probably with a PAC, a premature atrial complex, the tachycardia starts. So what happens when we have a patient with an accessory pathway with Wolff-Parkinson-White syndrome? Again, the electrical conduction system of the heart, sinus node. The sinus beat starts from the sinus node. It goes down the AV node, but look, this patient also has an accessory pathway, so the activation also goes down this way and starts activating the ventricle eccentrically, as we call it, and that's why we see this delta wave on the surface EKG, which represents immediate ventricular activation that doesn't happen through the normal conduction system of the heart. So we have the short PR interval because the conduction is very fast down the accessory pathway, and the delta wave. We call the syndrome WPW from the three wise men that reported it, Wolff-Parkinson-White, in front of the staircase of Mass General Hospital many decades ago. They had made the observation based on the surface EKG of the patients and the symptoms that the patients were describing. When the presence of the accessory pathway leads into an SVT, we call it atrioventricular reentrant tachycardia, as I said, and we have two types of them. The most common one is the orthodromic AVRT, when the impulse goes down the AV node and then quickly finds its way up through the accessory pathway. And so the reentry happens down the AV node, up the pathway, and that's why it's a narrow complex tachycardia. This happens 90% of the cases of AVRT, but in 10% of the cases, we may have this sometimes a little more confusing situation when the impulse goes down the pathway first and up the AV node next. So because the ventricles get activated first, we have a wide complex tachycardia that sometimes we need to differentiate from ventricular tachycardia. So this is a patient with, like the patient that I was reading the Holter on, that goes from sinus rhythm to the initiation of the AVRT. And so what happened was a PAC started going down the normal conduction system and then quickly up the accessory pathway. And that's why the SVT is narrow complex, because the ventricles get activated through the normal electrical system first. The AVRT in general tends to go faster than AVNRT and is more prone to present with electrical alternance on the surface EKG, and I will show an example of that. When we have AV dissociation, atrioventricular dissociation, then by definition, this SVT cannot be an AVRT. We have to have one-to-one association of atrial and ventricles. Slowing of the tachycardia rate on development of bundle branch block ipsilateral to the pathway is a characteristic of AVRT, and this is a little more esoteric for cardiologists and electrophysiologists, but it's always an interesting finding to have. So this is an example of a patient of ours that young patient, 16-year-old, that had developed palpitations, and this was his presentation EKG. Again, we see a fast, regular tachycardia with a right bundle branch block aberrancy, a little wide, but really not as wide as ventricular tachycardia would be, or antidromic AVRT would be. So right bundle aberrancy, just because it's a very fast rate, but otherwise narrow complex tachycardia. And then we start looking for P waves. And in this case, I think you will all agree that we can see some P waves in there, almost in the middle between the previous and the next QRS interval. So a long RP tachycardia, and this can be consistent with AVRT. This patient we did take to the lab and we confirmed it. This was another patient with AVRT confirmed by the EP study, a little less fast, but still almost 180 to 200 beats per minute, with P waves again much out of the previous QRS, so a long RP tachycardia. And here is the example of the mechanical alternance that I mentioned. As you can see, there is some fluctuation, almost a beat-to-beat fluctuation of the amplitude of the QRS, just from the way the heart shakes inside the pericardial sac because of the fast rate. A couple of rare but interesting subcategories of accessory pathways. One is the Maheim pathway, the Maheim fibers, which corresponds to atriofascicular pathways that connect the right atrium directly to the right bundle, and they only conduct anterogradely. So the pre-excitation has a typical left bundle branch block pattern. And then there is this condition that it is good for everybody to know about. We call it PJRT, or permanent junctional reciprocating tachycardia, which is common actually in younger ages, infants, toddlers, young children. And the worrisome part about this is also, although the heart rhythm is not very fast, it can be incessant. So by the time the patient presents to us, they may have developed tachycardia-mediated cardiomyopathy. So it is very important to recognize it early. The pathways, the accessory pathways, connect, as I said, the atria and the ventricles, and they always transect the grooves of the mitral valve and the tricuspid valve. And for us electrophysiologists, it's also important to try to characterize the geographic area where these pathways are, because it is important for us to know how difficult it will be with ablation to get to that spot. Where the pathways are frequently found are on the right side around the tricuspid valve, the right free wall, the posterior septal area, and the anteroseptal area. This is the area that can be a higher risk because it's close to the normal conduction system of the heart. So by ablating here, you can create complete heart block. And on the left side around the mitral valve, the left free wall is actually the most common area where pathways are found, but also left posterior septal area. What do we do when a child is referred to us with the diagnosis of Wolff-Parkinson-White syndrome, either because they developed palpitations and then an EKG was done, or because someone did an EKG for another reason and they found the pattern of the WPW on the surface EKG? We have to risk stratify the children and decide whether the condition is something that we need to do something about it, either treat with medications or with an ablation, or it is a condition that we can just watch the kid as they grow up with the hope that they may actually outgrow it. So the first important thing is to look at the EKG and see if the pre-excitation is persistent or if it is intermittent. If it is intermittent, so some complexes are wide, some complexes are narrow, then and the child has no symptoms, then the child can be just watched without any additional measures being taken. But if the pre-excitation is consistent, is persistent, then an exercise stress test would be advised. If during the stress test the pre-excitation disappears, then that is a low-risk situation and the kid can just be watched. If the pre-excitation remains, then we refer the child for an electrophysiology study. If during the electrophysiology study we can induce atrial fibrillation that conducts down to the ventricles very fast, then the patient has to be considered relatively high risk and referred to a cardiologist for counseling regarding whether being on medications or considering an ablation, as I am saying here. If the during the atrial fibrillation, the conduction is very fast, over 250 beats per minute, then the patient has to be referred for a catheter ablation. If during the EP study the patient also has inducible supraventricular tachycardia, then there may be a benefit to an ablation procedure. This involves asymptomatic patients. If the patients have symptoms, have palpitations, have documented supraventricular tachycardia, then an ablation is a class 1 A indication, and most electrophysiologists would recommend that. So this is an example of a patient with an intermittent pre-excitation on their baseline EKG, and you can see how some complexes are wide complex and others are narrow complex, short RP, normal RP. And this is the condition that we said that in an asymptomatic patient could be benign. This is, on the other hand, a patient with constant pre-excitation. So every beat is the presence of a delta wave is there for every beat. You can see there a negative delta wave and a short RP for every complex. this is a patient that we would refer for further evaluation. And why do we refer for further evaluation? Because in the setting of atrial fibrillation, an accessory pathway can conduct very fast and can result in ventricular fibrillation and death in a very low percentage of patients, 0.2% per year risk for sudden cardiac death or resuscitated cardiac arrest due to atrial fibrillation degenerating into ventricular fibrillation in the setting of a pathway. Here is an example of a narrow complex tachycardia, and here is adenosine given during WPW. After some ectopy, the tachycardia stops and the accessory pathway is evident. We said that for the asymptomatic patient with persistent pre-excitation, we take them to an exercise stress test, and this was a patient of mine. And we will see actually what happened during the stress test. The QRS complex became narrow, and she started conducting with a normal, almost normal PR interval, still some pre-excitation there, but then with the evolution of time, the pre-excitation disappeared, and this was felt to be a benign accessory pathway that we did not end up doing anything else, as the patient did not have any palpitations. We differentiate WPW or supraventricular tachycardia, which is white complex, from ventricular tachycardias, as I said before, as well as atrial flutter or atrial fibrillation with aberrancy. And this is something that we have to do in the emergency room and to decide what the best way of managing these patients would be. So this is how atrial fibrillation can conduct down an accessory pathway faster to the point that ventricular fibrillation may be induced and the patient may have a cardiac arrest. The next mechanism we will talk about briefly is the atrial tachycardia, and this is an example of a patient that was taken to the EP lab surface EKG, normal sinus rhythm, before and after we induced the atrial tachycardia. On the surface EKG, you can see more P waves than QRS complexes. When we put the intracardiac catheter in, this is sinus node, P wave QRS, and this is the atrial tachycardia, 2 P waves for every QRS, 2-to-1 AV block during the tachycardia. The atrial tachycardias are mainly automatic, coming from the crista terminalis in the right atrium, the atrial appendages, the pulmonary veins, the ostia of the pulmonary veins, and may be also seen in patients with structural heart disease, but mostly in patients with chronic lung disease, pneumonia, myocardial infarction, and acute alcoholic binges. Reentrant forms tend to be paroxysmal, whereas automatic forms tend to be incessant and catecholamine insensitive. The atrial tachycardias can be fast, but not necessarily super fast, less than 200 beats per minute. And when there is AV block during the tachycardia, that strongly suggests the presence of an atrial tachycardia. They're usually long Rp tachycardias, so you can see the P wave somewhere between the 2 QRS complexes. So this is an example. Somewhere in the right atrium, this other focus other than the sinus node takes over and starts firing these beats, and the heart rate is as fast as the rate that this beat is firing, here about 120 beats per minute. Lastly, atrial flutter is another common arrhythmia, less common compared to the rest of the SVTs, but 10% of patients with structural heart disease may present in atrial flutter. More frequently, atrial flutter is associated with the presence of structural heart disease, valvular heart disease, hypertensive heart disease, coronary artery disease, previous cardiac surgery. And since the great discoveries of Dr. Waldo and his colleagues back in 1977, we know exactly where the typical atrial flutter circuit lies inside the right atrium, and we will talk about this in this next slide. So we know that the typical atrial flutter is reentry around the tricuspid annulus on the right side of the heart. The typical flutter is counterclockwise activation, as we describe it. Reverse typical is the clockwise activation of the tricuspid annulus. And this is counterclockwise typical atrial flutter, and how it goes around the tricuspid annulus. And here is the classic sawtooth presentation of the P waves in the inferior leads 2, 3, and F, negative P waves in these leads, and positive P waves in lead V1. This EKG is consistent with typical atrial flutter. As we can see it here in a real-life situation, the negative P waves in the inferior leads and the positive P waves in V1. This is what we call an atypical atrial flutter. Similar circuits can form around other structures. The mitral annulus can be one of them, but you can see how although we have the positive P waves there, the inferior leads do not suggest the sawtooth presentation that we saw before. I will open a parenthesis here to talk about a condition that we include in the supraventricular tachycardia lecture, but it does not really represent a supraventricular tachycardia in the same way that, like the mechanisms that we have discussed. The inappropriate sinus tachycardia that can occur because of reentry around the sinus node or the perinodal atrial tissue. It's a slow, relatively slow tachycardia, 130 to 140 beats per minute. A large portion of the patients that I have seen, and this publication actually agreed with me, about 90% of them are females, and for some reason these females are healthcare professionals. The definition of inappropriate sinus tachycardia is the presence of persistent sinus tachycardia at more than 100 beats per minute during the day, with excessive rate increase in response to activity and nocturnal normalization of the rate as confirmed by Holter. The tachycardia and the symptoms are not paroxysmal, they are constant. The P wave morphology and the endocardial activation is identical to the sinus, and exclusion of secondary systemic cause, like for example a patient who is hyperthyroid and has tachycardia because of that, cannot be considered as having inappropriate sinus tachycardia. The management is with, I should say, notoriously ineffective, but we always try with beta blockers, class 1 indication, verapamil or diltiazem, 2A, and catheter ablation, really the last resort, really a decision of desperation when the inappropriate sinus tachycardia is so bothersome. In the past few years, a new medication has come out. It's a selective inhibitor of the pacemaker current, the IF, so having special action only in the atria, suppresses the heart rate by targeting the hyperpolarization activated HCN gene family. There has been extensive studying in patients with heart failure and sinus tachycardia, and there, these patients actually had a mortality benefit by being on the medication, the ivabradine, but it has also been tested in a more limited way in inappropriate sinus tachycardia. And what it does, it takes the heart rate from a distribution during the day that is in the red color to slower in the blue color, and those 10, 15, 20 beats per minute that the heart rate slows down can make a patient much more comfortable and with less symptoms. The presenting symptoms: palpitations, lightheadedness, dyspnea, and these symptoms now account for all the SVT cases. Syncope, rarely, but if the heart rate is 250 beats per minute, it can happen. Neck pounding, as we discussed, is pathognomonic for Avnrt. Sometimes patients don't experience palpitations, but they experience anxiety, fatigue, nausea, general malaise, and some other patients show up because of chest pain or heart failure, as we discussed for my elderly patient, or tachycardia-mediated cardiomyopathy. As we discussed, there is an extremely small incidence of mortality, 0.15% per year in patients with WPW, or 2% of non-lethal cardiac arrest in various series.